Next one is next speaker is Dr. D Avila from Mount Sinai in New York. He's going to talk about durable pulmonary vein isolation. Can the mission ever be accomplished?
Thank you very much. I'm actually Brazilian. I happen to work in New York, so I'm sorry for my accent at the end of the day, but you guys have to stay there. You have no option. And so what I'm going to try to talk to you is about this discussion about pulmonary vein isolation. So first of all, why should we think about durable pulmonary vein isolation? To make it short, I think that if the veins play a role in this AFib business, there is no reason for you not to aim, not to shoot for durable PVI. Because a procedure with an endpoint as pulmonary durable PVI should at least have the same kind of outcome of a procedure when you compare that to a procedure without durable PVI. The problem is that PVI is a perfect endpoint for a procedure. It's already tough enough to compare different strategies from lab to lab. And if we want to do some sort of comparison, we have to start with something that is clearly and easy definable, which is like PVI. We also need PVI because what you see here, you can damage the vein, but as you can see there, even when in cases where you have a big delay between the A and the V, if you pace inside the vein, you can conduct in a one-to-one fashion, so you can have atrial fibrillation again. So you have to get pulmonary vein isolation all the time. How well can we as a community do this? And that's exactly what the problem is. As you look at this table here, you see that when we take into account the number of pulmonary veins reconnected during the restudy, during the second or third procedure after initial PVI, you can see that the number of veins that is actually disconnected, it's very disappointing. Not to mention that the number of patients who have all veins disconnected after the procedure, it's extremely disappointing. It's almost like we don't know what we are doing. If our goal is to get durable pulmonary vein isolation, how can you possibly justify that only 4 to 5% of the patients who return to the lab will have disconnected, all veins will be disconnected there. So what we are doing, we have to revisit this in some way. And even when you look at the more recent data, this is the study that was presented in Europe a couple of months ago. And just to summarize that, they were basically comparing if complete and incomplete ablation around the veins would give you a different clinical outcome. And it seems that when you go for a complete encircling of the vein, you have a little bit better, not very good, but a little bit better clinical result. But look at the number of veins who were reconnected, shown here by the number of gaps that you see when you bring the patient back 3 months after the procedure, despite the presence of symptoms. It's extremely disappointing again. Basically, all the veins were reconnected. 70% of the veins were reconnected when you do complete encircling, and 90% of those was reconnected when the encircling was not complete. And it's the same thing. You just look at the published data and we'll see that, for instance, in this case here, that the investigators were just going around the vein, and once they could see electric isolation, they would stop and finish the procedure. In another group of patients, they would wait for an hour, and in case of reconnection, they would ablate again. And as you can see, that kind of strategy didn't play any role because all the veins, 90% of the veins were reconnected in both groups. This is actually interesting. Can you advance the next slide for me? It's not working here. Can you advance the slide? So, but again, as you read these numbers, you will see that typically the number of reconnected veins is way too much. And that was not different for us. But because we could not accept this kind of results, we decided to think about different strategies to, you can advance this manually if you want. We had to think about the different strategies to see if we could improve the results. Because the first thing that you have to think about is, Is radio frequency such a bad energy sources that's why we never get durable PVI? We got to blame somebody, right? You're going to blame something. Is this because RF it's not the good way to go? I don't think so. If you actually look at the kind of lesions that you can produce with radio frequency, you got to go forward, right? Got stuck to this one again. Just advance it manually. Oh, it doesn't go? Okay, great. Well, let me just skip a bunch of slides then. And what you have to keep in mind is that when you look at the thickness of the left atrial wall, it's very thin. And typically, if you have a stable catheter in a stable position, you should be able to create easily create a transmural lesion in that specific left atrial wall. So if that's the case, why this thing is not durable? Why we always see this huge amount of reconnection in most of the patients who come for an AFib ablation? There are basically two reasons for you to do that. One is if your lesion is not transmural, and the second one is if your lesion is not continuous. No. And I think that okay, I knew I shouldn't have. Why don't you go minimize and just skip this one? But what I was trying to say is that in my mind, initially I always thought that transmurality would be the main reason for us to be so inefficient. But as you think about it, that can't be the reason. Because for the most part, this is not working. Do you want me to stop the presentation and go to the next speaker? Because no, it's just not working here. But they can't advance it manually, right? It's not my fault, it's their computer fault.
We'll give you 5 extra minutes, don't worry.
No, but let me just, it so cannot be transmurality because the lesions must be transmural for most of our atrial applications. You have a decent and good contact there. So what we need to do is to make sure that we have good contact if we want to improve the rate of durable PVI. And at the same time, we also need to make sure that we have a continuous line. And there are a couple of tricks that you can use to do that. They're simple, but then to show it to you, I would love to have the figures to make it easier for both of us. So the minimal changes, right, are very important in my mind. Things like the size of the dot that you project on your atrial shell, it's very important. Just by using a 4, and now we're using a 2 millimeter dot, it did change our results in terms of continuity. Because what you need to make sure you have a continuous line is to have a lot of overlap between all those lesions. By simply doubling the size of the dot, you lose a lot of this continuity, which again has to be the main reason for you to have such a high pulmonary vein disconnection. So this is it looks simple, but seems to be very important too. So as I was saying before, just keep in mind that basically when we take patients back to the lab, at least this was the case in the past, and 80% of the veins, it seems fair to assume, would be reconnected. It's hard to understand. Why is that? If radiofrequency seems to be a safe and very good energy source. So the problem has to be because the lesion is not transmural or is not continuous there, or a combination of both. You see, this is a mathematical model, but it summarizes what we actually see, what we believe we are doing in the heart. And as you can see, within few seconds, if you have good contact, and that's exactly why contact force is so important, you should be able to easily create a transmural lesion in the left atrium. So within 15, 20 seconds, your lesion depth should be around 5 millimeters. So this is important because when you look at the thickness of the left atrium, it's never more than 5. So there is a reason why radiofrequency seems to be so inefficient. One of the problems that we have, and that's why in the EP lab we say that AFib ablation is a race against edema, is because when you deliver a bad lesion, characterized here by poor contact, when you do that, what you're going to do is simply to create edema in that specific region. And when you do that, what's going to happen, this is data coming from Dr. Callan's laboratory, the edema will basically double the size of the left atrium wall, making it extremely hard for you to successfully ablate that same spot if you don't finish the lesion there. There is some data suggesting that this seems to be the case. When you deliver a bad lesion, in this case here, because you have low power or you have a low time integral force, when you deliver a bad lesion, this is your initial lesion in that specific part of the vein, this is why you will have, even if you have good lesions for the rest of the vein, this is what's going to cause the veins to reconnect. I completely agree with Dr. Callas that contact force will change the way we deliver RF. But just going back a little bit, because it's not available in the United States at this point, just keep in mind that one important thing that we have to do in the EP lab, it's always track the impedance drop. There is a weak correlation between contact and impedance drop as we ablate. But one thing is clear, the only reason for the impedance to drop is because we hit the atrial wall or the ventricular wall in this case here. As you can see here, I start my ablation, my impedance will drop because the wall temperature will go up. As soon as I stop my application, my impedance will go back to a similar level that I had before my application. So again, if you don't have hitting, the impedance won't change. In other words, you cannot cause any lesion if your impedance doesn't drop. It's a very simple thing that you can do in the EP lab. If you deliver an RF lesion and this is the kind of impedance that you see, it means that you're not causing any kind of lesion whatsoever. And this is a very simple thing that you can do. It's not simply what you do with every single lesion, but the way you deliver them. This is, in our mind, this is the right way to do so. You have to do a continuous line with a significant overlap between the lesions here. Because if you do it this way, if you just jump from one side to another, even if you deliver a good lesion there, what's going to happen, as you can see here, and this is what we call the jump index, what you're going to see if you have a high jump index, you are more likely to have reconnections. Because again, it has to be continuous. If transmurality is not a problem, and you create edema even with a good lesion, if the lesions are not side by side, they're not continuous, you will increase the chances of having a reconnection right there. And that's why I was telling you about the size of the dot, which sounds silly. But let's just look at this for a comparison. I did place these points here manually, but as you can see, this is a 2 millimeter and this is 4. So when you ablate, if you ablate using a 4 millimeter dot, your overlap is gone. The amount of overlap that you are going to have, just compare these 3 images here, it's completely different. And this is like a real case. As you can see here, when I ablate, I try to go with a 2 millimeter dot, and then if I just change the size of the dot to 4, this is the representation that I'm going to have. So we did, simply by changing from 4, which was what we were using before, to 2, we did increase the amount of disconnected veins that we see during the redo cases. It's also seemed important to us to change what we are doing. In the past, we're always starting ablating the ablation in the hardest areas to ablate. In other words, on the right side along the ridge, and in the left side along the ridge, and for the right in the roof. But that seems to be the wrong approach, at least in our hands. Because think about edema. If edema is going to be there immediately after your ablation, within 1 minute, you want to start and finish your circle in an area where it would be easy for you to deal with edema. I don't want to deal with edema in an area where my contact, like the ridge, is poor. So if I have to choose an area to start, I should always start from the posterior wall. Again, we decided to do this because the other approach, starting in the harder areas, was not working for us. So, and this is just an example here. This is a representation of every single application, and I got this data from Anderson's. As you can see here, in this particular case, the ablation started here in the posterior wall, and then we went anterior. This is a different case where the ablation started anteriorly, and then we went around to complete the circle. 3 months after that, this vein was disconnected, and this vein here was reconnected. Again, it seems to be a silly, simple change, but at this point, I think we are here to fine-tuning what we do in the EP lab. As Dr. Callan said, we understand the pathophysiology there. And if you put lesions really close to each other with a good overlap, watching your impedance drop, looking at your contact force, and you start from the posterior wall, you should be able to get a complete isolation without placing any lesions on the carina. Putting a lesion on the carina, it's very misleading because you can get pulmonary vein disconnection despite the presence of very bad lesions along the veins. So you can do the carina after finishing the circle. That's okay, because you can validate your circle before burning the carina. So in our lab, we, as much as we can, sometimes you can't do that, we never place a carina lesion before we are done with the circle. And if you follow these rules, what you're going to see from time to time, many times actually, is that even when you have a large gap along your circle, the veins are disconnected. So we decided to look into this a little bit better to decide what to do with the visual gap in the presence of a disconnected vein. And as you can see, the visual gap can be seen around the veins, anywhere. And this is the case that we took into consideration before we planned for this study here. This is my patient. I did this ablation here, and when I went to the left side, because the right side, because the esophagus was here, the veins were disconnected, and I decided not to ablate. So the patient went home and later came back with a fib. I took the patient back to the lab, and sure enough, my reconnection for the right veins only was right along the gap. So it seems that the visual gap, even in the presence of a disconnected vein, may play a role on the reconnection strategy. This is, then we took like 20, 30, around 30 patients, and this is what we did. We were starting here, as you can see, we went anterior, and then when we get to this point, the vein got disconnected, despite the presence of a large, like 30 millimeter visual gap. And when you give adenosine to these patients, you have reconnection again through the visual gap. So the only way for you not to see adenosine-mediated reconnection was to burn the gap again. So when you look at the data, we took these 23 patients here, and to make a long story short, after getting vein disconnected and checking for entrance and exit block, adenosine was given. And as you can see here, in 30% of these patients, there was dormant conduction, and 70% of that was through the visual gap. So again, you have to place the lesions in a way that you will never leave a visual gap there. So the visual gap should be ablated. It has to be a complete circle. By using this kind of strategies, we were able, at least in our lab, to change our previous results. As you can see here, we look at 81 consecutive patients, half of them with paroxysmal AFib, and 14 of them came back to the lab because of recurrence. And now there was a big change. Instead of having 80% of the veins reconnected, we had to deal with a different reality. In this population, using the strategies that I just shared with you, 90% of the veins were disconnected. So it seems that when you add, and there are other things that I'll discuss with you in a minute, you can actually change from 80% reconnection to 80% disconnection. And because we were moving, I guess, in the right direction, we also decided to go for a very different philosophical change. We decided that we should report our results in a different way, not simply talking about free of recurrence or free of AFib. Because the goal of your procedure, if the goal is to go for PVI, you should be able to do that in a safe way. And this has to be part of your successful report. And we just published this like a month ago. We came up with this idea. It's just a concept, okay? I think it's the first time we tried to create like a assessment score for AFib ablation, and I'm sure you will have a different opinion about this. But what we are doing here is basically trying to show you in an objective way that the redo rate and the pulmonary vein reconnection, you can use those variables to assess the quality of what you are doing. If you have a huge redo rate and a huge reconnection rate, there is room for improvement. On the other hand, if you have a minimal redo rate and a very small reconnection rate, but a very high complication rate, if you had to use like a lot of energy to do that, you also have to reanalyze your strategy there. And that's the whole point here. If you have a high redo and a high pulmonary reconnection rate, you can clearly see that there is room for improvement. And of course, if you have a high complication rate, it will denote that you have a poor ablation strategy that you have to change in some way. This is a little bit of the summary, and this is how we would love to report our results from now on. If you look at the worldwide data, and this is a number that we had to create, right? The number wasn't there. I would say that if you take these 20,000 patients into account with a classic redo rate of 30% and a classic reconnection rate of 60%, and these are the complications that are reported there, the quality score number would be 130. If we look at our own data, specifically if you look at our radio frequency data, our score is twice as much. Why is that? Well, in this specific situation is because our reconnection rate was smaller, like 20% of the veins were, the redo rate, we had to redo 20% of these 170 patients. Our reconnection rate was around 25%, different from 80%. And we had few complications, as you can see here. So because of that, the number is this. So, but now I can clearly compare my results to Dr. Natali's results. Natali reported this data last year, if I'm not wrong. And as you can see, his alpha score, it's better than mine. Why is that? Well, because as you can see, again, his reconnection rate was smaller, and his complication rate was smaller than mine, was lower than mine. So what I'm trying to do, and just because of this, now we don't get like our arterial stick anymore. We measure blood pressure through the radial artery, and I'm changing my energy delivered a little bit. Instead of burning with 30 watts, I'm trying to burn with 35 watts. They use 40 watts because I want to bring my reconnection rate even lower. I want to go closer to what he has. So, but now it's clear to me why needs to be done for me to improve my results. Instead of simply saying that my successful rate, my PAF freedom is X, Y, and Z. In some ways, I believe that we almost write the manuscripts backwards because we already know the conclusion. It's 70% freedom from AFib, and that cannot be right. And it's not right because the technique that we use in the lab, it's completely different. And I want to learn from others what they do better so I can move in that specific direction. So to answer your question, if this is possible, if dural PVI is possible, I believe so. But for you to do that, there are lots of changes that you have to promote. At least in our lab, that's what we had to do. We had to incorporate, as Dr. Callens was saying, general anesthesia, ice and jet, their suggestion. In our hands, our ablation strategy works better with the flexible sheaths. It's also important for you to deliver the best possible lesion in the beginning of your ablation strategy. That's why contact force, it's so important. And you have to do this in a point-by-point way with no carinal lesions, leaving no visual gaps when you go around the vein. And each application should have at least a 10% impedance drop, because again, it doesn't matter what the contact force says. You can have 50 grams. If the impedance doesn't drop, there is not enough contact or enough footprint between the catheter tip and the tissue. So you can just show a high force by putting a pin and changing the shape of the catheter. There is not enough surface contact. So the contact force, it's one thing that you can do to improve your lesion set, but impedance has to come down. Also, once the lesions are delivered, I deleted the slides for obvious reasons, so you have to proper test your lesion set. And we always do that with patient capture, adenosine, and high doses of isoprel. And I think this is important because once, this is almost like a fluorotime. Once you decide to put the fluorotime in your report and use that as a quality control, the fluorotime drops immediately in your lab. So if you decide to report your pulmonary vein reconnection rate as part of your report as the quality control in your lab, I guarantee that there will be a competition inside the lab, and everybody now will pay attention to the reconnection rate and use that as a way for you to say that the ablation strategy that you're using is more appropriate than what you're doing in the past. 45 seconds. Thank you very much, and I'm sorry for the slides. Thank you.